So the exciting thing about this study is that it basically represents one of the largest real-world patient population cohorts that are receiving long-term prophylaxis for hereditary angioedema. And this included patients with normal C1 inhibitor, HAE, and this is a population in which the clinical data are limited. At every encounter with a patient, whether it be telephone, live, etc., that is a good time to rediscuss prophylactic options. And so with this data in mind, it's reassuring to know that we have yet another great option, and this one being oral, to provide to a patient who's wishing to be on prophylaxis, with the aim obviously to be to reduce the severity, the frequency, and the extent of these attacks that happen in HAE, and to hopefully reduce the use of rescue medication. And so essentially to regain kind of your calendar and own it instead of be dependent on when's my next attack going to happen. Berotralstat is a solid option for patients and physicians who are prescribing this medication in really various degrees of attack rate at baseline. And so it is a strong option when considering initiating prophylaxis as well as continuing prophylaxis. When physicians are considering adherence, persistence, and tolerability of a drug such as berotralstat, the data that was put out recently speaks to that, in that these patients are being more adherent, and we always talk about compliance and adherence once a prescription is written out. And then we obviously want tolerability, and it's no good if a treatment is not tolerable or more burdensome than the disease itself. And lastly, that kind of naturally causes or creates persistence. And with those three, essentially, you see better control of the disease. And with it come things such as improved quality of life, especially if they've been studied in the trials, and really presenteeism, which is the patient being able to now, on this new path with a new therapy or continuation of therapy, to be able to achieve the things they kind of wished or dreamt they wanted to achieve, such as the neighbor across the street being able to maybe mow the lawn, or their sibling being able to go on cruises or flights. All these things that kind of held them back, now with the success of this prophylaxis, to be able to live life the way they want it to be. And that, by the way, is the tagline of the Hereditary Angioedema Association, is to normalize life. So we all want our patients to lead a normal life. Yeah, the evidence presented really solidifies berotralstat as an option that could be first line, as well as if patients may not be satisfied with their current prophylactic therapy, to switch gears and consider an oral option. And that includes things such as needle fear, fatigue, etc. It presents yet another option to add to the armamentarium of medications that we really didn't have as little as 16 years ago in this modern era of HAE treatment. No, I think these findings show that broadly, uh, this prophylactic can be effective in any patient profile. And the added kind of icing on the cake is the indication just dropped to 2 years of age now. And so that really helps some of us who treat a lot of children and young adults with HAE, not just older ones, an option that's viable and crosses or spans a greater age category. I mean, I don't think there remain too many unanswered questions as far as durability or tolerability. Obviously, we continue to have vigilance in any drug that's out there, but whether it's the specialty pharmacy data, obviously the clinical trials, the pivotal phase 3 data that is read out really point to the fact that this has efficacy and safety, both things we look for, and in my mind, equally from a medication. And then it's a matter of achieving success with the patient and making sure, like we mentioned earlier, there's compliance with the regimen and reporting back on any kind of attacks or safety signals to make sure that they're being taken care of in this prophylactic environment. The new data with this study include the fact that patients with one or more attack per month at baseline had significant and sustained reduction in attack rates after Orladeyo was initiated. And this was regardless of baseline attack rate or HAE type. And then most of the patients with no baseline attacks per month maintained that attack rate of 0 attacks per month following initiation of Orladeyo, speaking to the really durability and reliability. And then attack rate reductions stayed significantly lower compared with baseline throughout an 18-month follow-up period. And so all these, to me, are readouts of the data that reassure the prescriber that a medication such as Orladeyo should be effective.